Delays in the diagnosis and treatment of drug-resistant tuberculosis are among the biggest challenges to TB control and elimination worldwide. In 2018, less than 40% drug-resistant TB cases were diagnosed, of which under 14% were cured. In 2019, there were over 10 million TB cases, of which 15% were resistant to at least one first-line drug. Drug susceptibility testing is a necessary step to determine the appropriate and effective treatment for a patient's TB infection. As a priority of patient-centered TB care, the WHO's End TB strategy calls for universal access to comprehensive drug susceptibility testing for all persons with any form of TB. This should allow for early diagnosis and treatment and drastically improve clinical outcomes for DR-TB. Conventionally, drug susceptibility testing for TB has relied on phenotypic methods, which are based on the observation of growth or inhibition of a bacterial culture in the presence of a drug. These methods, while being comprehensive, are highly time-consuming, have rigorous biosafety requirements, and require significant hands-on commitment. But there is an alternative. In Mycobacterium tuberculosis, drug resistance arises primarily from spontaneous changes known as mutations that occur in the bacterial DNA. This makes rapid and easier to use molecular DST methods highly effective for DR-TB diagnosis, as they can rapidly detect the presence or absence of specific bacterial mutations associated with resistance to certain anti-TB drugs. The WHO recommends two types of technologies for molecular DST. I'm sure you're all familiar with the first type, known as nucleic acid amplification tests or NATs. These include rapid molecular tests such as the Expert MTBRIF Ultra and Line probe assays. Since their introduction, these tests have contributed to a substantial decrease in the diagnostic and treatment delays by increasing the number of RIF resistance cases being detected. Current rapid tests typically detect resistance for one or more of the first-line drugs, rifampicin and isoniazid, and some second-line drugs like fluoroquinolones. Decades of research has contributed to our knowledge of genetic mutations associated with drug resistance. Detection of resistance to all existing, new, and repurposed TB drugs would require interrogation of hundreds of mutations over 90 bacterial genes. Rapid diagnostic tests are designed to target short regions of the DNA that harbor the most common mutations. Therefore, they're not as comprehensive as conventional phenotypic testing. These limitations can be addressed by next-generation sequencing technologies that can provide DST as comprehensive as phenotypic testing within a much shorter time. So what is next-generation sequencing? NGS, or next-gen sequencing, in fact is a collective term for technologies that can determine the entire genome sequence of an organism using rapid and high-throughput methods. Whole genome sequencing, as the name suggests, is used to determine the entire DNA sequence of an organism. In the case of Mycobacterium tuberculosis, whole genome sequencing works best with bacterial DNA extracted from culture isolates. Targeted sequencing is used to determine the sequence of specific regions in the genome when whole genome sequencing is not possible or required. As this method involves amplification of regions of interest in the DNA, it can work directly with DNA extracted from sputum samples and is therefore more suitable for molecular DST. Targeted sequencing can offer comprehensive DST for TB samples, direct from patient samples. It allows detection of resistance to first and second line drugs in a single test within as little as 48 hours. It can be scaled for any number of samples and has lower biosafety requirements than culture. hope I've been able to convince you that sequencing-based DST holds great potential for TB. It can help clinicians to prescribe the right medicine to patients from the outset of their treatment. This can result in savings in treatment costs and improve global cure rates. Thank you for listening.